The drop-first model came about in an era where there wasn't a lot of treatment options. But nowadays, we have a lot of different extra options, such as SLT. In the Asia-Pacific region, a lot of these patients, they may have a notion of having drop-first deeply hammered into their head. And so sometimes when you suggest different starting point, something like laser to start off, sometimes they can see you as a little bit aggressive. However, I do find that in the last 5 years or so, more patients are being receptive to having SLT as a first treatment. They have read somewhere on the internet or perhaps done their own research. They understand that SLT as a first treatment is better than just having topical therapy. Looking at the study and from my own practice, we're looking at a 20 to 30% efficacy. And I generally let the patient know it's fairly similar to the first topical treatment. And the other advantage of SLT is that alleviates the burden of using topical therapy. And probably more importantly speaking, for someone like myself who does a lot of incisional surgery, is that sometimes these effects can adversely affect your surgery outcomes and negatively affect the success rates. When I see someone newly diagnosed, I do separate them into mild to moderate glaucoma, or if they're advanced. At the same time, I try to determine, first of all, what age they are, their severity, but also what kind of life expectancy and their general health status, because that's going to affect how aggressively you're going to treat someone. Whether you start with laser or drops or perhaps all of them, but that's going to affect how you consult them in that initial consultation. And that's going to make a big difference in terms of telling them what the expectation and what their disease or condition may be like in the future. I would consider using SubCyclo when the patient has failed SLT plus or minus topical therapy. Certainly, SubCyclo has been known to be safer than ThermoCyclo. That's because of the pulses of energy that's delivered. It does not use a sustained source of heat, so it causes less tissue destruction, and as a result, less inflammation, less complication, less risk of hypotony, and so on. To me, there's a big overlap between the indication of the two. You'll be thinking about using stents pretty much the time you'll be thinking about SubCyclo. I think personally there will be a situation where perhaps the patient does not want surgery. There might be contraindication to surgery. They might be too sick to have surgery. In those times, I would tend to probably choose towards SubCyclo. But quite often, they're almost interchangeable in some sense. And to be honest, recently I've been doing two of them together in some special cases. With SubCyclo, I tend to do 80 seconds per hemisphere. That's using sweeps. And the duty cycle is around, I think, 31.3%. That's 1/3. You can vary the settings a little bit. If the condition is a bit more severe, you can increase the power. You can increase the duration of your treatment time, and that would be the main thing I do. I perform SubCyclo and ThermoCyclo in my procedure room in my private clinic, and I do that usually under a periboba. And I tend to use a 50 mix between lignocaine with adrenaline and a long-acting anesthetic, such as marcaine or Narapin. If I have Hyalase available, I'll use it at the same time. I'm very fortunate to have all three modalities in my private clinic at my disposal at any time. The combination of the three gives me confidence that I can manage the full spectrum of glaucoma, from mild to the refractory to the most advanced glaucoma, and both in the chronic sense and if they come in as an emergency. My takeaway message is, if you don't have the whole set, but I think you should consider trialing them out, and perhaps they can work well and make you offer more to your patients.